Hi, my name is David Owens. I'm one of the cardiologists at the University of Washington, and I'm happy to be able to talk to you today on the topic of preventing sudden cardiac arrest in athletes and young adults. This is a topic that has become increasingly important to me. I run the cardiovascular genetics clinic and the hypertrophic cardiomyopathy clinic here at the University of Washington, and I encounter a number of young people who've had sudden cardiac arrest and fortunately have been resuscitated and survived. But I know that there's a number of people who never make it to my clinic who have the same type of heart disease. So today's talk is going to focus on the issues surrounding sudden cardiac arrest and also some of the controversies and how the best methods of screening. So my disclosures, I do serve on the advisory board for the National Fabry Disease Registry, which is sponsored by Sanofi Genzyme. And then I do receive funding from the Pac-12 to study ECG screening practices among Pac-12 participants. And that's a 2-year study that we just got funding for. So to begin, I'm going to talk about a 22-year-old male who is a patient of mine. He had no prior past medical history. He's asymptomatic, was playing competitive soccer when he collapsed. And this is a schematic of what the rhythm would have been like at the time of his arrest, of ventricular fibrillation. Fortunately, his teammates knew CPR. They successfully defibrillated him once EMS arrived, and he successfully made it from the playing field to the hospital. This is the EKG that was performed in my clinic when I saw him, but probably also at the time of his arrest. And you can see these. This is a markedly abnormal ECG with deep T-wave inversions in the lateral and lateral precordial leads. And this is a pattern that is almost pathognomonic for apical hypertrophic cardiomyopathy. And that raises the question of, was this cardiac arrest preventable? Could we have identified this individual ahead of time before his cardiac arrest and maybe taken appropriate precautions? So this is the outline of my talk. I'm going to be talking about the scope of the problem. I'll be talking about disorders that cause sudden cardiac arrest. And finally, we'll be talking a little bit about some of the opportunities for screening for sudden cardiac arrest, including some of the new ECG criteria that have arisen. So sudden cardiac arrest is defined as the abrupt and sudden loss of heart function, usually due to abnormal heart rhythms. Although the overall rate of sudden cardiac arrest is low, the number at risk is relatively high. It's estimated that there are approximately 2,000 deaths per year among those less than 25 years of age, although the estimates do vary widely, and we think it's on the order of 0.5 to 4 cases per 100,000 youth. This is a very difficult case capture. There's no mandatory registry. We're largely relying on public reports of these events in order to understand how frequent they occur. Overall, if you look nationally, the survival from sudden cardiac arrest remains quite low, on the order of 15 to 20%. That is a little bit higher here in King County, and it really depends on regions and how much infrastructure is involved in having the resources to respond quickly to these types of events. It's also been noted that on-site AEDs, defibrillators, improve survival, and there's been a lot of effort to try to make those more publicly available. So in terms of sudden cardiac arrest in the young, it's really a disorder of high school. And this is data from Jonathan Dresner, who's one of the sports medicine family practitioners here at the University of Washington, and reported out the number of sudden cardiac arrest based on school age, so elementary, middle school, high school, and college. You can see the vast majority of these cardiac arrests are occurring in the high school age. And this may be because of the effects of puberty, what's happening at the heart level, for example. The heart goes through a period of tremendous change during this period. But it also may be related to the fact that this is the age when a lot of kids are starting to engage in more competitive athletics. We know that exercise increases the risk of sudden cardiac arrest for just about every individual. This is data from the Physician Health Study that looked at 122 sudden cardiac arrests among 21,000 physicians. Sudden cardiac arrest was considered to be exercise-related if it occurred during or 30 minutes following exercise. And what they found is that the overall relative risk of exercise was about 17-fold That is, every episode of exercise that somebody engaged in, there was a 17-fold higher risk of sudden cardiac arrest during that period of exercise. If you look over here at the graph on the right, you can see that this effect is modified by the frequency of exercise. And so people who exercised frequently, here in green, had only about a 10-fold increase in risk every time they exercised. But people who were sedentary and got up and exercised had a nearly 70 to 80-fold increased risk of sudden cardiac arrest during that period of exercise. It's important to understand that the absolute risk of sudden cardiac arrest for each individual episode of exercise is extremely low, and that there is, even despite this data, there is a net benefit for exercise in reducing mortality. When we look specifically at the risk of sudden cardiac arrest in young athletes, this is data from Italy. They looked at it prospectively at a 21-year follow-up period, looked at athletes ages 12 to 35 years of age. They had over 29 million total years of observation and 2.4 million athlete years of observation. So it was a fairly robust observation period. They noticed that sudden cardiac arrest occurred in the setting of exercise in 89% of athletes and only 9% of non-athletes. Now, athletes are going to exercise quite a bit more than non-athletes, but this does represent a significant increased risk of exercise, increased risk of sudden cardiac arrest for every episode of exercise. Over here, the sudden death rate per 100,000 person years in athletes was about double that in non-athletes. In Italy, the data suggests that soccer, basketball, and swimming were the most common sporting activities that led to sudden cardiac arrest. So when we look at exercise and sudden cardiac arrest overall, it's important to recognize that the net effect of exercise is believed to be beneficial and should be encouraged in nearly all individuals. Sudden cardiac arrest, we believe, requires a susceptible substrate, something wrong with the heart, and then some type of a trigger that causes the cardiac arrest to occur at any individual point in time. The susceptible substrates are usually subclinical coronary artery disease in older individuals, and in younger individuals, congenital or genetic heart disease or channelopathies. But then, as a trigger, a number of things can occur, but exercise may also serve as that trigger. Exercise increases the adrenergic stimulation, can induce myocardial ischemia for people who are prone to that. It can cause dehydration and electrolyte imbalance, all of which can act as a trigger for sudden cardiac arrest. So every 2 to 3 days, a U.S. student athlete experiences sudden cardiac arrest. And although that risk is low overall, these deaths tend to be tragic. They're devastating not only to that individuals' families, but often to whole communities, whole schools who are impacted by these types of events. There's data that suggests that these rates of sudden cardiac arrest seem to be increasing over the last 10 years. This may be related to more competitive exercise at a young age, may also be related to some type of changes in the underlying heart structures. We also note that males or boys are much more likely to have sudden cardiac arrest than female or girls. Is this a biological difference, or is this a sociologic difference because of the quantity and intensity of exercise? It's unclear. When we look at the causes of sudden cardiac arrest in young athletes, I apologize, the formatting on this changed when I switched this over. But sudden explained death is the largest cause of sudden cardiac arrest, followed by hypertrophic cardiomyopathy here in red, followed by unexplained left ventricular hypertrophy in pink, and then purple should be anomalous coronary arteries. So in this data, sudden unexplained death occurred in about 40% of individuals, hypertrophic cardiomyopathy occurred in about 26%, and anomalous coronary arteries occurred in about 15 to 20%. We'll go over those entities in a little bit more detail. It's important to know that this data is controversial and it's not universally accepted, and the cause of sudden cardiac arrest may depend upon the population being studied. The data I showed you is up here on the top. In the U.S. registry here, sudden unexplained death, 34%, hypertrophic cardiomyopathy, 24%, and some of the other causes here. I don't want to go over all of the details of this study other than to just demonstrate that the colors change fairly markedly depending on the studies being looked at. So if you look at the U.S. military, if you look only at NCAA level athletes who have passed away, if you looked at in the United Kingdom, and if you look in Italy, the results differ quite a bit. In fact, in Italy, arrhythmogenic right ventricular cardiomyopathy, shown here in the peach color, is among the most common causes. Hypertrophic cardiomyopathy only accounted for about 9% in that study. I also want to go over some data looking at some of the things that modify the risk of sudden cardiac arrest. So we know that, as I showed you before, exercise can increase the risk of sudden cardiac death, and this was shown in Dr. Marin's study as well. So Dr. Marin is one of the gurus of hypertrophic cardiomyopathy. He's also published quite a bit in the field of the sudden cardiac arrest in athletes, and it finally came about. We actually showed some of this data in an NCAA study, but he showed it in his population as well, that exercise, competitive exercise, training, and recreational exercise all increase the risk of sudden cardiac arrest. They also found that high school and junior high school aged kids were higher risk, and also that football and basketball seemed to be the highest risk within that study, with soccer being also common. There may be some ethnic and racial issues that underlie some of these differences. They did notice that African American athletes were at higher risk, and African American athletes do play more basketball or football. Whether that is related to the type of sport or something having to do with the underlying ethnicity and predisposition to disease is unclear. This is data that we published in 2012 looking at sudden cardiac arrest in NCAA athletes over a 5-year period and showing much the same thing. And the Black Division I basketball players were the highest risk individuals, and they had an overall risk of about 1 in 4,000. So 1 in 4,000 Black Division I basketball players would suffer a sudden cardiac arrest in any given year. One of the things that has come up, and we'll talk about later in the talk, is whether or not we ought to be screening only athletes or we should be screening non-athletes as well. Dr. Marin has shown this data proposing that non-athletes should be considered for screening as well. In this study, non-athletes made up 72% of the population, athletes made up 28% of the population, and sudden cardiac arrest death rate in his study was lower in athletes than it was in non-athletes, and this is having to do with the state of Minnesota at the high school level. And this suggests that non-athletes have a higher risk and should therefore also be included in potential screening. And so I put a question mark there about this data because it does conflict with some of the earlier data, but it does raise some important ethical issues when it comes to targeting our screening efforts. I next want to turn a little bit and talk more specifically about some of the disorders causing sudden cardiac arrest. And they basically fall into 3 general categories. One is genetic conditions, congenital heart abnormalities, and then some acquired conditions. The genetic conditions can be cardiomyopathies, such as hypertrophic cardiomyopathy, or an entity called arrhythmogenic right ventricular cardiomyopathy. They can be aortopathies from Marfan syndrome or other inherited disorders, where the primary cause of death is an aortic dissection. There can be channelopathies, where the primary cause of death is an abnormal heart rhythm with a structurally normal heart. And then there's some congenital heart abnormalities, such as anomalous coronary arteries, Wolff-Parkinson-White syndrome, and congenital aortic stenosis that can increase the risk of sudden death. And then there are some acquired conditions, such as subclinical coronary artery disease, myocarditis, or an entity called commotio cordis, which we'll talk about in just a second. So hypertrophic cardiomyopathy is among the most common causes of sudden cardiac death among high school and college age individuals. Hypertrophic cardiomyopathy is pathologic thickening of the left ventricle of the heart, usually and most often of the interventricular septum separating the left ventricle and the right ventricle. It is caused by genetic mutations within the cardiac sarcomere, shown down here in the bottom left. This is the main contractile apparatus of the heart, and of the peripheral muscle as well. And changes in some of the proteins in here changes the contractile function of the heart, which then can predispose to sudden cardiac arrest. Most commonly, hypertrophic cardiomyopathy begins in adolescence between the ages of 12 and 21, and this represents the highest risk period for sudden cardiac arrest. As the heart is growing, it is the most electrically unstable, and these individuals that are at especially high risk of sudden death. We think that the overall prevalence is about 1 in 500, although there's some new data that suggests that the lifetime prevalence rather than the cross-sectional prevalence is higher than this and maybe as high as about 1 in 200. How is hypertrophic cardiomyopathy recognized? Well, it turns out that only about 40% of HCM patients are identified because of the onset of symptoms. They can be chest pain with exercise, shortness of breath, overall something that I refer to as just exercise limitation. People aren't able to do as much as their peers. Palpitations and fainting. Those are the symptoms that patients with hypertrophic cardiomyopathy often have. But 60% of hypertrophic cardiomyopathy patients don't have any symptoms. They present because they've had an acute event, sudden cardiac arrest or a stroke most commonly. They're picked up because of routine examination, and they detect usually a heart murmur. There's some efforts with family screening, and then some other screening efforts, genetic screening, or maybe some of the sports screening efforts that we'll talk about in a little bit. Important to know that hypertrophic cardiomyopathy is predominantly, but not always, obstructive. Hypertrophic cardiomyopathy has 1/3 each resting obstruction, a 1/3 exertional obstruction only, and 1/3 non-obstruction. So people who are non-obstructive generally don't have heart murmurs. People with exertional obstruction, people don't have any obstruction at rest, but they only have it when they exercise. They may or may not have a murmur at rest, and people with resting obstruction will have a murmur at rest. This obstruction is dynamic. It's due to interactions with the mitral valve. I'll show that on the next slide. And it depends on loading conditions. And because of that, we can do some maneuvers within the office space that help to unmask some of these murmurs and some of this obstruction. So this is an example of of a patient with hypertrophic cardiomyopathy, some thick septum over here. This is the mitral valve, left ventricle, and aortic valve over here. And as the heart is squeezing, the mitral valve gets pushed up against the septum, and it essentially creates a flap valve that obstructs blood from leaving the heart into the aorta. This causes the pressure inside the heart to become elevated, and the flow of blood across this area to become very high. It's this high velocity blood flow that we can hear with a murmur, and it typically creates just a systolic murmur. This obstruction is dependent on loading conditions. That is, anything that we do that shrinks the size of the ventricle is going to bring the mitral valve closer to the septum. It's going to make the obstruction worse. And conversely, anything that increases the size of the ventricle is going to push the mitral valve further from the septum and make the obstruction and the heart murmur less. The maneuvers we can do in the office space, the ones that have the most ability to distinguish the types of murmurs, are Valsalva, and then doing a squat to stand maneuver. So if you have somebody do a Valsalva, or you have them squat and stand, if they have hypertrophic cardiomyopathy over here on the right, you should see that the murmur increase in intensity. Both of these maneuvers are going to decrease preload, bring that mitral valve closer to the septum, and cause an increase in the murmur. Aortic stenosis, however, is fixed, and it's not dependent on preload. And so the murmur may decrease, if anything, with these types of maneuvers. Now, that it's challenging. I see nothing but hypertrophic cardiomyopathy, it seems. And it's challenging even for me to distinguish how the intensity of the murmur changes with these maneuvers. Sometimes it's clear, but oftentimes it's not, even when I know that they have provocable obstruction based on echocardiography results. Next, in Italy and also in the United States, one of the more common causes of sudden cardiac arrest is arrhythmogenic cardiomyopathy, sometimes referred to as arrhythmogenic right ventricular cardiomyopathy, and sometimes referred to as arrhythmogenic right ventricular dysplasia. This is a genetic condition caused by mutations in the cardiac desmosomes. Desmosomes are sort of structural proteins that are between cells and provide structural integrity for the myocardium. What happens in arrhythmogenic cardiomyopathy is there's gradual fibrofatty replacement of the right ventricular myocardium most frequently. It has also been documented in the left ventricle, which is why the official term has dropped right ventricle from the terminology. And this can lead to ventricular arrhythmias, which can be the first manifestation of the disease. And as the fibrofatty replacement increases, you start to get right ventricular dysfunction and right ventricular failure. But oftentimes these ventricular arrhythmias, which occur at the microscopic level, are the first presentation. Exercise can worsen this condition. There's some very elegant data that now shows this, and most of us now who treat these patients recommend against vigorous and endurance exercise for these individuals because of the concern that we're speeding up the natural history of the disease. And finally, this is a fairly rare disorder, fortunately, about 1 in 2,000 and 1 in 5,000 individuals. This is a sort of a autopsy slide showing what's going on. The left ventricle down here and the right ventricle up here, and you see this more glistening type of material up here, which is the fibrofatty changes within the right ventricular free wall, and the left ventricle in this individual is relatively unaffected. Next, long QT syndrome, which is a channelopathy. It causes prolongation of the period of cardiac repolarization. Is another one of the common causes of sudden cardiac arrest in young individuals. Long QT syndrome occurs in about 1 in 2,500 individuals. It's genetic. There's a number of different subtypes. There are 3 common subtypes, however, long QT 1, 2, and 3. Here are some of the genes involved and the ion channels that are involved and prevalence. Long QT1 is sudden cardiac arrest during physical activity. It's usually brought about by adrenergic stimulation. Long QT2 stereotypically may happen in the period of loud noises or acute sort of stress. One anecdote that seems to be tossed around in the boards is that these individuals wake up and they're startled by their alarm clock and then experience sudden cardiac arrest. And finally, long QT3, which is bradycardia dependent and can occur during sleep. This is one of the few cases in which knowing their genetic status can have a big impact on the types of therapies we prescribe to these individuals. Here's an example of long QT syndrome, which is basically diagnosable by ECG. I took out the slide looking at the population curves of long QT syndrome, but we consider any long QT interval over 500 milliseconds as being definite long QT syndrome. Now, whether that's medication-induced or not, we'll have to learn more about what medications they're on, but certainly raises concern about a genetic predisposition to disease. Just going to go over just briefly about how we measure long QT syndrome. So first off, we would measure the RR interval. We would then measure the QT interval, starting here at the Q wave and then going all the way down to the end of the T wave. We mark the end of the T wave by where the tangent of this terminal portion of the T wave meets the baseline. We take this as the QT interval. In this case, it's 590 milliseconds. And then we correct it for the RR interval by taking the square root of that RR interval in seconds. And then you end up with a corrected QT interval, and for this individual it's 539. We would call this definitive long QT syndrome, and in absence of any medication effects, this individual would be diagnosed with long QT syndrome. There is a rare channelopathy called Brugada syndrome. I bring it up because it has a very distinct and ECG over here that, if you see it, is basically diagnostic. It is a gain-of-function mutation in the sodium SEN5A channel, and this is opposite of the long QT syndrome. So this actually is a gain of function mutation. Long QT syndrome is a loss of function within the same gene. People with Brugada syndrome have the risk of sudden cardiac arrest, and about 1/3 of these individuals, sudden cardiac arrest is their presenting symptom. We would move forward with an ICD if there's syncope or sudden cardiac arrest, and there's some criteria that we use to help triage individuals who may be at risk of sudden cardiac arrest. But the pattern is such, here if you look in the ECG tracing over here, it's the patterns in V1 and V2, sometimes into V3, that are, there's various type 1, type 2, and type 3 patterns. This is a type 1 pattern that's most commonly or most strongly related to risk of sudden cardiac arrest. It is a ST elevation that goes into a T-wave inversion with a very slanted ST segment, which is very distinct from right bundle branch block or somebody who has just ST segment elevations. So this is a type 1 Brugada pattern. This ECG would be diagnostic, and then we'd look at his family history, we do some genetics and try to understand their risk. Another one of the more surprisingly common causes of sudden cardiac arrest are coronary anomalies, and that's a little bit scary to us as cardiologists because these are usually very silent. They're silent on ECGs. They can cause chest pain symptoms, but when you look at autopsy studies, these are one of the more common causes. There's a couple of high-risk features that we pay attention to. The highest risk situation is when we have an anomalous left coronary artery coming off the right coronary sinus that runs between the pulmonary artery up here and the aorta down here. There's this area right in here can be an acute takeoff from the aorta that can get pinched. There's a space in here that can also be pinched. Sometimes this is the cause of angina, chest discomfort with exercise. Sometimes these individuals don't have any preceding symptoms. When we detect an anomalous left like this, we will surgically repair this. If we detect an anomalous right, that gets a little bit trickier, and we have to do a lot more investigation to understand that individual's risk. Finally, I want to talk about commotio cordis, which is not a problem with the heart itself, but a phenomenon that can occur during sporting competitions. What occurs in commotio cordis is that hard objects, a hockey puck, a lacrosse ball, a baseball, or a fist or elbow in, say, martial arts, strikes the chest right in front of the heart at just the right point in the cardiac cycle, and which then induces an abnormal heart rhythm. Often it's straight into ventricular fibrillation. There's really no way to detect individuals who are at risk of this ahead of time. There's been a lot of efforts to have proper protective gear to help prevent this. But just as important is the availability of AEDs on site at playing fields in order to be able to respond to these types of events. If you Google commotio cordis, there's some very heartbreaking and devastating videos of individuals who have had cardiac arrest as a result of commotio cordis. Chris Pronger, who was a St. Louis Blues player when I was a kid, had a sudden cardiac arrest on the ice, was fortunately resuscitated on ice in front of 20,000 people in the stands, but then went back to playing professional hockey. So finally, I want to talk about screening for sudden cardiac arrest and some of the issues related to this. It is a more controversial area than many people recognize, and we'll go over current recommendations, some of the controversy, and some of the hope and concerns about using ECG as a way to try to detect some of these underlying heart conditions. So can we do anything to prevent sudden cardiac arrest used in athletes? I think there's a two-pronged approach. One is to screen for the conditions that cause sudden cardiac arrest, and the other is to have these AEDs available and to improve CPR and AED training. The American Heart Association scientific statement is this. It continues to support pre-participation cardiovascular screening for student athletes and other participants in organized competitive sports as justifiable, necessary, and compelling on the basis of ethical, legal, and medical grounds. Indeed, pre-participation screening for athletes is viewed as an important public health issue. So the American Heart Association is on board with doing screening for these types of heart conditions. What they recommend is a 14-element pre-participation cardiovascular screening process that involves a personal history, family history, and a physical examination. The elements on the personal history are things like asking these young adults and athletes if they have exertional chest pain or discomfort, if they've had unexplained syncope, if they have excessive shortness of breath, if they've ever been told they had a prior heart murmur, if they have elevated blood pressure. And these 6 and 7 here were just added. It used to be a 12-element recommendation, now it's 14. Have you ever been restricted from sports in the past, and why? And have you ever had any prior heart testing, and why? On a family screening, we want to know, is there any cardiovascular death less than the age of 50? Is there any disability from heart disease and a first-degree relative less than the age of 50? And is there any known family history of hypertrophic cardiomyopathy, dilated cardiomyopathy, long QT, Marfan syndrome, or any of the other clinically important arrhythmias that we talked about? Finally, we do a physical examination. We listen to the heart in a resting position, upright and supine. We do those provocative maneuvers, the Valsalva or the squat to stand. We look for coarctations by assessing femoral pulses. Well, that's challenging to do. We look for physical stigmata of Marfan syndrome, which are elongated of fingers, broad wingspan, high arched palate, things like that. Lens dislocation is another one. And finally, we assess their blood pressure as well. So that's the 14-point element pre-participation screening recommendations from the American Heart Association. This is done routinely across the United States. But I think it puts a lot of burden on primary care providers to do this and do this well. 14-part PPEs or exams are required by some states. They're required by individual schools and required by team. The process is decentralized. It is performed by primary care providers primarily. And there's scant data for the effect. We think and we hope that we're doing so good by doing these examinations and taking this history. It's not clear because nobody's ever really studied this on a large scale level. Turns out in our data and others that there's a high proportion of adolescents and elite athletes who endorse some of the symptoms we talked about. High proportion of these adolescents, I'll show this on the next slide, almost 50 to 70% of these young individuals will report chest pain with exercise or undue shortness of breath with exercise, or even fainting in the setting of exercise, which is not all that uncommon. And it can be really hard to differentiate these symptoms from what is benign and what is scary, and also what heart murmurs, whether the heart murmurs themselves are benign or maybe they represent underlying hypertrophic cardiomyopathy. This is a response rate to the PPE questions from our Nick of Time Foundation experience. We looked at 1,300 students aged 13 to 24. And when we looked at exercise-related symptoms, a quarter of them reported chest pain with exercise. Some of that may be asthma-related. 25% reported lightheadedness with exercise. Another quarter had unexpected shortness of breath. 13% had syncope. 11% felt their heart racing. Family history, you can see the data here on an examination. About 8 or 9% of individuals were felt to have a murmur on examination. So overall, close to 70% of students had more than one or more finding on the history and physical. And even when we thought we were triaging this, about 31% of them had concerning symptoms even after this initial evaluation and consultation with a physician. So the 14-point questionnaire is helpful, but it also is picking out a lot of individuals who would then need additional testing if we were following this by the rules. So the question becomes, can we do better? One of the things that's come up, and I'll show some data on this, is whether or not we should be using an ECG. And it tends to be a very hot topic right now. People who think we should screen with ECG think that the current methods are ineffective, that the ECG is capable of detecting some asymptomatic disorders, but that there's a learning curve involved, and we have to get better at this in order to use it on a large scale. The people who argue against ECG screening think that there's a high false positive rate with ECG. It adds a lot of financial and non-financial costs. There's limited resources already, and to get hundreds of thousands of kids to have ECG takes up those resources. There's no evidence that it improves mortality. And then there's this question about whether or not it's ethical only to screen athletes, or should we be doing this on a larger scale? Well, a number of these conditions we talked about are likely detectable by ECG. In fact, there's data that says that 90% of asymptomatic hypertrophic cardiomyopathy is detectable on ECG. Unexplained left ventricular hypertrophy likely is detectable, or arrhythmogenic right ventricular cardiomyopathy, dilated cardiomyopathy, long QT syndrome definitely is. Brugada and WPW definitely are detectable by ECG. Possibly detectable aortic stenosis if it has significant effects on the left ventricle. Myocarditis if it's active. Not detectable are things like aortopathies, anomalous coronary arteries, and of course commotio cordis, which occurs in structurally normal hearts. We know that ECG is more sensitive at detecting underlying heart disease. These are 4 separate studies looking at all total, probably about 10,000 athletes. And in this, ECGs detected between 66 and 100% of the abnormalities found, whereas history and physical only found about 33% of them. So we know that the harder you look, the more you find. Challenge, though, is that athletes who exercise quite a bit have physiologic adaptation to exercise in ways that can resemble disease states. For athletes that do a lot of endurance exercise, their heart starts to dilate as a response to the high cardiac output that they experience repetitively. For people who may do a lot of strength training, their hearts may thicken and become in response to the higher blood pressures of training, and this may mimic hypertrophic cardiomyopathy. And so these normal hearts and people who have very normal changes in response to exercise can often get mistaken for underlying heart disease. So there's some overlap between the EKG changes due to athlete's heart and those due to cardiovascular disease, but it turns out that it's not as much as we think. ECG increases the sensitivity of detecting abnormalities, but traditional criteria have poor specificity. The ECG criteria that we use in the hospital were developed for an older population. They were developed for older individuals who show up to the emergency room complaining of chest pain, and we want to know, is there hypertension causing the left ventricular hypertrophy? These ECG criteria have never been tested and were not made for young individuals who are healthy and essentially asymptomatic. And so we need to develop some new ECG criteria targeted for our population being tested. There are costs of ECG screening. These are financial costs for the cost of doing the test. There are human costs because of the people doing the test, but also the effects on the individuals who may have a false positive result. And there's opportunity costs. That is, individuals could be doing other things besides getting their ECGs or performing their ECGs. And we talked a little bit about some of this, the cost of false positive, economics, more testing, psychological anxiety or worry that you're causing in the athletes, and then perhaps some health consequences, especially if we have to exclude young adults from exercise, or we create the fear that they may have heart disease and they exercise less because of that. Because of this controversy, the American Heart Association put out a statement about the use of 12-lead ECG as a screening test for detection of cardiovascular disease in healthy general populations of young people. This was published nearly 2 years ago now. And in these recommendations, they strongly recommend a Class 1 recommendation to use the 14-point screening guidelines as part of a comprehensive history and physical exam to detect or raise suspicion of underlying heart disorders. They place the use of ECG as a Class 2 recommendation, which is in an ECG in addition to H&P may be considered in a relatively small cohort of young people, not necessarily limited to athletes, if there's close physician-provider involvement, sufficient quality control. And finally,
Class 3 recommendation for mandatory or large-scale screening, in part because of these concerns about cost and effect of the false positive results. So in reality, however, ECG screening is here and being performed at some level. ECG screening is the standard of care for athletes in Europe in international sporting competitions and almost all U.S. professional sports. College players who are looking to make it into the NFL go to the combine. At the combine, every one of those athletes will receive an ECG and an echocardiogram as part of their as cardiovascular screening. Similar is true of NBA and professional soccer players in the United States. This is true in virtually all athletes across the world who want to play on an international level. In fact, one of my patients was detected because she had an ECG when she made it to the international ultimate frisbee competition, and they required an ECG in order for her to compete. Nearly half of all NCAA Division I programs perform ECG screening as a part of their athlete evaluation. Some also use echo, maybe about a third of programs. And then there's also been this public demand for ECG screening of adolescents that has arisen in just about every major community across the United States. Local nonprofits and medical systems have arisen to try to fill this need and are offering either free ECG screening or ECG screening for a low fee in a hospital setting. We've been involved in trying to repurpose some of the ECG criteria and tailor it for athletes, mostly targeted athletes who are symptomatic, and trying to understand which of the changes to be concerned about when we're evaluating a symptomatic athlete, but may also have some utility in screening young people and college and high school level athletes, and also professional level athletes. It's important to know, this first came out in 2010. The European Society of Cardiology was the first driver of this. Stanford came out with some criteria in 2011. John Dresner, again, of the family medicine and sports medicine community here at the University of Washington, brought an expert consensus panel together here in Seattle in 2013. We called these the Seattle criteria, and these have had two other refinements. And the latest one is the International Consensus Criteria, which is due to be published in the next couple of months. Again, trying to tailor the ECG to an athletic and otherwise healthy population. These new criteria are primarily expert consensus. There is some data, and we're constantly looking for new data to enhance and support the recommendations that we have for these documents. And with these serial improvements in the criteria, we've noticed that the false positive rate from the ECG has been progressively improving, and with the international consensus criteria, we think we have the false positive rate now down to about 2 to 3%. However, there's the data in large populations is largely lacking, and that still needs to be acquired. This is the authors of the Seattle criteria, and this was the first sort of big international group trying to get together and come up with a criteria. These are the Seattle criteria. I'm not going to go over each of these in detail, but they're here for reference. I will point out that we put a lot of effort into defining what is normal, because one of the biggest problems in screening young, healthy individuals is recognizing what is normal and not over-testing. So we put a lot of effort into defining what exactly is normal. And you can see some definitions over here of what we decided is abnormal. These are changing in the next couple of months, and so I don't want to go over each of those criteria. I want to point out a couple of things, though. There are, for young individuals and young individuals who exercise, we see a lot of changes due to high vagal tone. And sinus bradycardia is almost universally the norm. We can see ectopic atrial rhythms, junctional escape rhythms, first degree AV block, and even Winky-Bach patterns. And we're not concerned. It doesn't necessarily mean anything structurally or electrically wrong with the heart. It's just that these individuals, when they exercise, end up with high vagal tone when they're at rest. We have some individuals, I've done some heart rhythm monitoring in some of my athletes that I see in clinic. I've had one marathon runner have an 8-second pause during sleep, which was not concerning to us because she had a structurally normal heart and was otherwise asymptomatic. Other common changes on the EKG include isolated voltage criteria for left ventricular hypertrophy. Remember that slide I showed you about the ways in which the heart can remodel in response to exercise? Left ventricular hypertrophy is usually not pathologic if it's voltage criteria only and not associated with any ST segment changes. Incomplete right bundle branch block is a very common finding, and early repolarization is a very common finding as well. This is an example of a very normal ECG in an athlete, in a young person, showing hypervoltage over here, showing the first sinus arrhythmia, some first degree AV block perhaps here, and ST elevations, which represents early repolarization. Another pattern of normal that we've learned about as we do this is variant of early repolarization seen in African Americans and individuals of African descent. So up to 3 to 5% of African American athletes show T-wave inversions in the anterior leads, and I'll show you an example of this on the next slide. But the definition of this is convex or domed ST segment elevation combined with T-wave inversions in leads V1 through V4 in individuals who are Black or African descent. Importantly, these changes normalize with the conditioning and represent some type of effect of conditioning and remodeling in response to exercise. So here's that two variants of early repolarization. Here on the left, on the A panel, is the early repolarization that's most common, and what we refer to on the ECG most commonly as early repolarization. But here's a pattern over here that some people would look at and think that this is markedly abnormal, when in fact this is a training effect. It is a variant of repolarization, domed ST elevation going into a T-wave inversion isolated to V2 and V3, sometimes, but less commonly, also affecting in V4, but never having T-wave inversions in V5 and V6. I want to point out there's a lot of emphasis on left ventricular hypertrophy voltage criteria and concern about that, and that is by far the most common reason for additional workup or unnecessary further evaluations for these athletes. This is a slide looking at the ECG findings in a population of HCM patients and a population of control patients. I just want to point out here that LVH criteria is very common in control patients. Up to 1/3 of individuals have LVH criteria, and this isn't athletes. This is just normal individuals taken off the street. For controls and hypertrophic cardiomyopathy, that number is a little bit higher. But because hypertrophic cardiomyopathy is rare within the population, you're so much more likely to be picking out this group if you see isolated left ventricular hypertrophy. And this is not worth additional evaluation. In fact, these abnormalities are the ones that classically, or more classically, define hypertrophic cardiomyopathy on ECG: Q waves, ST depressions, and T wave inversions. And 90% of patients with hypertrophic cardiomyopathy are going to have these changes, and these are the changes we key in on, and not the isolated LVH with voltage. If you want to learn more about these ECG criteria, we've developed a website. I put this up here. This is goes over the Seattle criteria from a couple of years ago. We will likely be updating this as soon as the new criteria are out, but this is a good learning resource for everybody. We've used this to show that these ECG criteria are teachable. No matter if you are a primary care provider, resident, attending, if you're a sports medicine person, or even if you're a cardiologist, learning about these criteria improves your ability to separate out the normals from the abnormals when doing this on a screening level. The biggest problem, as I mentioned, is identifying the normals. And if we can do a better job of recognizing what a normal ECG looks like, then that's the biggest hurdle to using ECG to detect underlying cardiovascular disease. But the ECG and detecting disease on ECG is just the beginning of the challenge. And there's a lot of gray zones between athlete's heart and disease, hypertrophic cardiomyopathy, dilated cardiomyopathy, and arrhythmogenic right ventricular cardiomyopathy, the most common ones that we get concerned about. There's a lot of gray zone there, and it takes a lot of knowledge and expertise to be able to differentiate these two without unnecessary and undue testing and without undue deconditioning and taking an athlete out of participating in sports for a period of 3 to 6 months, and I try to avoid that as much as I can. I will point out, and I will emphasize, that any screening program that is attempted requires a streamlined referral and evaluation channel to providers who have a lot of expertise in these areas, both on the adult level and the pediatric level, in order to minimize the amount of unnecessary testing and minimize the amount of worry for the athletes. So I want to just go over finally some of the real world data and some of the stuff we've been involved in, and show how some of the ECG screening works in practice. We've published this. We've used this, our efforts, primarily under the guise of research, in order to learn more about this and incrementally improve how we can do this. We've published our series of cases among the University of Washington and the athletes over a 5-year period. That was in the Journal of American College of Cardiology. We did a 35-site feasibility study published in the American Journal of Cardiology. I'll show that on the next page. We've looked at high school students and have a number of manuscripts on this. And we also have done screening on the Seattle professional athletes, but have not published any of that data. So this is data from the multi-center, multi-institution study. We looked at 31 different colleges and universities, looking at 17 different sports. Oops. We had over 5,000 athletes. This ranged from Division I to Division III. This is the data showing that 33% of them had abnormalities by history, 2% had abnormalities on physical exam, and 4%, using the Seattle criteria, had abnormalities on ECG. We used this and were able to detect 11 cases of WPW, 1 large ASD with RV dilatation requiring surgery, and 1 individual with hypertrophic cardiomyopathy who was disqualified. This individual, after surgery, was able to go back to sports, and any individual with WPW and has successful ablation is allowed to go back to competition. And our goal with this isn't to identify and disqualify. Our goal in this is to identify, treat, and return that individual to a healthy life of exercise. We've been involved in a number of youth heart screening events through the Nick of Time Foundation. The Nick of Time Foundation is a nonprofit started by Darla Valenti and Sue Apodaca. Darla's son died of hypertrophic cardiomyopathy. It was a football player, ward number 58 here, and died of hypertrophic cardiomyopathy. And ever since then, she's been on a mission to screen area high school kids. And I'll show you how we do that in just a second. We primarily focus in the Puget Sound area. We have done outreach up to Bellingham, down to Vancouver, Washington, and over to Ellensburg as well. This is a big collaboration between the physicians of UW-Medicine, Seattle Children's, and the Nick of Time Foundation. What we do is we have the students all fill out a questionnaire. We do blood pressure assessment. The medics, local medics show up to help with that, and that's fantastic. We do physical exam by miscellaneous providers. We have a 12-lead ECG performed. We've been interpreting by the Seattle criteria. We're updating that to the newest ones. Importantly, and this may be one of the more important things that we do, we have on-site CPR and AED education for each of the students. We have the students meet with a physician, go over their questionnaire, ask them questions in more detail, go over the ECG, and then we do a limited on-site echo if there's abnormal symptoms, history, or ECG, and then we arrange any necessary follow-up. We've used this for research. All of our data is coded, collected, and stored. We've screened over 15,000 students to date, and we have all these ECGs anonymized and digitized.
The abnormalities detected to date, by far most common, are bicuspid aortic valves in Wolff, Parkinson, White. We've had some individuals with severe bicuspid aortic valve with aortic enlargement who required surgery within the next couple of months after we detected them. Hypertrophic cardiomyopathy, dilated cardiomyopathy, long QT syndrome, ASDs, VSDs, enlarged aortas, and anomalous coronary arteries. We've detected all of these on the 15,000 kids that we have screened to date. And important to know that all of these individuals had prior pre-participation evaluations clearing them for sports participation, and yet had these underlying cardiac abnormalities. There's limitation to the data that we've presented because we don't always have the follow-up data. These are often done outside our systems, and we don't always know when we flag somebody for follow-up what becomes of that evaluation. We also don't have data, as much data as we would like, about false negatives, although our rate of screening people with echocardiograms at the time on site is quite high, so we do have some data on that. And finally, I want to talk briefly about sudden cardiac arrest legislation. Particular states have started to adopt legislation directed at reducing the sudden cardiac arrest among the young. This is on a state-by-state basis. Some have are requiring pre-participation evaluation, just that 14-point evaluation. Right now, most states don't require it. Some school districts do. Some non-school associated teams do, but it's usually not a requirement at the state level. So there's been some legislation trying to require it. There's been some legislation attempting to require physicians or coaches to become more educated about sudden cardiac arrest and the causes. And then also some efforts to require CPR and AED training in schools. And Darla Valenti has been instrumental in passing some legislation here in the state of Washington, at least along these lines. In 2015, Texas came very close to passing legislation requiring ECG screening for athletes. And it passed I believe the Senate, but did not pass the House. And that would have been a first for any state. It would have been a big leap. And I personally, and I back the American Heart Association on this, is that we still need to do more research and streamline the process before mandating ECG screening is the right thing to do. I don't know that mandating ECG screening will ever be the right thing to do, but at least the mass level screening, we need to make sure that we're doing it right, that we're not creating too much anxiety, that we're not disqualifying individuals inappropriately, that it's cost effective, and that it is something that's not going to overwhelm the healthcare system. So I think we're still quite a bit of work to do before we get there. So conclusions, sudden cardiac arrest in adolescence is often associated with exercise, is always traumatic, but is fortunately quite rare. Many diseases that cause sudden cardiac arrest can be identified by ECG. The guidelines recommend pre-participation evaluation screening based on personal history, family history, and physical exam. And incorporating ECG into adolescent and athlete screening may be beneficial, but we need resources and informed providers before we can do this on a large scale level. So thank you very much for your attention. I appreciate the opportunity to be here and talk about this. I want to give thanks to the individuals who have participated in some of the data I've presented, in particular the UW Sports Medicine Group, who in many ways is leading the charge on this, Jonathan Dresner, Kim Harmon, Hank Pelto, and Ashman Rao, Jack Salerno over at Seattle Children's Hospital, Jordan Prutkin here at the University of Washington as our electrophysiologist who's most involved with some of these efforts, and then many Nick of Time Foundation volunteers, Darla, Sue, the EMTs who help with every screening event, the sonographers who come out to help, and any of the local companies that have offered their support for these types of efforts. Thank you very much.